The broadcast is now starting. All attendees are in listen-only mode.
Welcome to today's webinar, Geriatric Emergency Departments, Past, Present, and Future Opportunities for Engagement. I would like to go over a few items so that you know how to participate in today's event. When you joined the webinar, you selected to join either by the phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of your control panel. You may send in your questions at any time, and we will collect these and address them during the Q&A session at the end of today's presentation. I would like to now introduce John Feathers, CEO of Grantmakers and Aging, and the moderator for today's webinar. John?
Thank you, Lucy, and thank you for all of you for joining us today. We want to particularly thank the West Health for their support of today's webinar, as well as the A Hartford Foundation for their continuing support of our webinar series. The emergency department, or ED, is often the entry point for older adults in the healthcare system and plays a unique role in setting the trajectory of care for this rapidly growing and often vulnerable segment of our population. Today's webinar will provide an overview of different ways in which organizations, including philanthropy, can be involved in helping improve emergency department care for older adults, specifically in areas related to research, education and training, and capacity building. We're very pleased today that we have three experts in these fields. Joining us today is first Dr. Kelly Coe, who is Director of Clinical Research with the West Health Institute, who has responsibility over a broad portfolio of applied medical research focused on senior-specific models of acute care with special emphasis on geriatric emergency care and telehealth. Prior to this role, Dr. Coe led research services for one of the nation's largest health information technology companies, partnering with health systems and provider groups to execute large-scale research studies, leveraging clinical data for research purposes. Marcus Escobedo is Senior Program Officer and Communications Director at the A Hartford Foundation, a private national philanthropy dedicated to improving the care of older adults. In addition to overseeing the Foundation's communications operations, his grants portfolio includes projects focused on improving care of older adults in the acute care setting and through policy and communication activities. Additionally, he oversees the Foundation's legacy medical education portfolio. Julio Urbina is the President and Director of the Healthy Aging Program at the Fan Fox and Leslie R. Samuels Foundation, and is responsible for helping the Foundation identify programs and projects that meet the goal of the organization, as well as developing new initiatives in which the Foundation is interested. Previously, he was an administrator at the Memorial Sloan Kettering Cancer Center and has directed emergency departments and emergency medical systems in New York City and Connecticut. Interestingly, and very much on target here, Dr. Urbina also served as a New York City paramedic for almost 20 years. Welcome to you all. As mentioned earlier, you can enter your questions at any time in the question box by typing them into the box that you find on the right side of your page. I will be reading those questions to our panelists after we're finished. So we want to start our presentation today with Kelly. So Kelly, I'll turn it over to you.
Great, thank you so much, John. You go to the next slide, please, Lucy. Great. So before we go into geriatric emergency departments, one area which I think is always helpful is to first provide some context as to why the ED represents an opportunity to help identify and serve the medical as well as the social needs of older adults. So first, we're all familiar with the growing senior population in our country, and with that comes an increasing demand on our healthcare system. And like many of us, when we have healthcare needs, whether it's because we can't get in to see our primary care provider, or perhaps we simply don't have one, or quite frankly, don't have anywhere else to go, seniors go where we all go. That is the emergency department. And this trend of the ED being utilized increasingly for both acute or traditional emergency services as well as non-emergency healthcare services is growing. And we know this because the number of ED visits by seniors has steadily increased over the last decade. And this is really what has fueled the idea behind the ED often being viewed as a front porch to the hospital. Commonly, the ED is the first touch point where seniors engage the healthcare system. So that's where the trajectory of their care is really set into motion, specifically through admission to the hospital or discharged home with the appropriate services and referrals. And while this might seem like a fairly straightforward concept, admit or discharge, the factors that go into this decision are what makes this such a challenging space, as these are both medical and social in nature. And in fact, this is largely one of the reasons why seniors represent just over 40% of all hospital admissions from the ED. And this really goes back to the challenge that a lot of our nation's ED providers have, who often find themselves in situations where they may feel comfortable discharging patients from a medical perspective, but knowing that social circumstances may trigger an event that would send them right back to the ED within a matter of days. And so all too often, the default is to admit seniors to the hospital where they'll have access to a social worker or a case manager to help try and address some of the non-medical circumstances that they may not necessarily have the resources to in the emergency department. Next slide, please. So this brings us to why, what is a geriatric emergency department? So when we think about a geriatric emergency department, one of the things that I always want to emphasize with all of those that are looking into this space is that more than anything, it's a culture of care, one that focuses on the specific needs of seniors across a wide variety of different senior-specific conditions, both medical and social. And often the goal, not always, but a common goal, is to identify appropriate opportunities to discharge patients to the home or community with the right resources to help enable aging in place. And we know that seniors, like many of us, would prefer to avoid a hospital stay, and this is exactly what GEDs aim to do, to try and help make that happen without compromising care. Now, obviously, this is a very tall order, and so not surprisingly, there's no one-size-fits-all to different geriatric EDs. In fact, GEDs are quite varied, and they are different based on the needs of the local population. For instance, one geriatric ED may focus their model of care around prevention of falls, given the history of local transfers from a local nursing facility due to falls, while others may focus on cognitive impairment, all depending upon the local needs of the population. But one thing I do want to stress is that often when you hear the term geriatric ED, you may think of this as a separate space, but that is indeed not necessarily the case. In fact, that's not even the norm, it's the exception. GEDs often exist within an existing ED space with just senior-specific protocols and processes for seniors. Next slide, please. So I do want to touch a little bit on where we've been as a geriatric ED community, and I'll go back just this last decade. There's certainly been other milestones that my colleagues will speak to here shortly, but a couple of key milestones that helped build the foundation of geriatric ED really started back in 2007. There was a paper published by the American Geriatric Society, quite literally titled The Geriatric Emergency Department, which really formally introduced this concept into more of the mainstream. Later, we saw in 2014 really a catalyst of significant investment in geriatric EDs. As a team of researchers from Mount Sinai in New York, in collaboration with others across the country, were awarded a CMS Innovation Award to help catalyze some of the research and the early stages of forming a national collaborative. And in that same year, we also saw geriatric ED guidelines published by leading geriatric and emergency medicine organizations. So now we not only have a CMS grant catalyzing research, but we also see a formal document here to provide guidance into what goes into a GED for all folks to access. And then as we evolve through 2016 and 2017, we see the number of GEDs growing to approximately 136, 140 self-reported GEDs out there. And then in that same year, in 2016, through funding from the GIA Hartford Foundation and West Health Institute, the Geriatric ED Collaborative, which was initiated through the CMS Innovation Award, was funded to continue to help build upon some of that early success. And then that brings us to 2017, where we started seeing additional investment from the nation's leading emergency medicine physician group, which recognized the need for a formal accreditation and established an accreditation program for geriatric EDs around the country. So that gives you a little bit of some of the key milestones. I'll turn it over to Marcus and Julio to share some of their insights about where we've been as a community as well.
Thank you, Kelly. This is Marcus from the John A. Hartford Foundation, and we can actually go back to the previous slide and stay there for just a moment. Kelly, thank you. That was a really good setup and description of where we've been in developing geriatric emergency departments over the last 10 years. I wanted to add that there is an even longer history of work that precedes 2007, which has helped set us up for this moment of time. As many of you know, and as John Feather mentioned, the John A. Hartford Foundation's mission is to improve the care of older adults, and we've been doing that for well over 35 years. Prior to 2007, much of our funding focused on building the workforce and the leaders with expertise in caring for older adults that are needed to really prepare the nation to deliver good outcomes and care to that population. And so this included helping develop leaders in geriatric emergency medicine. It was really part of our 25-year project with the American Geriatric Society. We called that the Geriatrics for Specialists Initiative, and it really did help seed the field. Through that work, we developed educational and curricular materials for trainees in the surgical and related specialties like emergency medicine. We used career development and research awards to foster the early success of academic researchers and educators who helped build the evidence base that we have now, the evidence base that got us to 2007, building out those geriatric EDs. And those leaders have been training the next generation of physicians as educators in academic settings. And I will say for funders in the audience, there's still a need for this kind of workforce development, this kind of funding of training and developing leaders in academia, in geriatrics, across specialties, across professions. But I will also note that, as Kelly indicated, the rapid growth of emergency departments that are focused on the geriatric population and some of the new opportunities that we have today in healthcare really do call for even more leaders in geriatric ED care, and for those leaders to transmit their expertise, to EDs across the country on a large scale. So with that, let me turn to Julio to offer his reflections on where we've been from the Samuels Foundation perspective.
Thank you, Marcus. This is Julio from the Samuels Foundation. When I'm looking at this timeline, I think about the fact that we all bring our previous experiences, whether they be work-related or personal, to our work, in philanthropy. And it's certainly my background as a paramedic in New York City. I saw firsthand, how older Americans or older adults were being treated in the emergency department, sometimes appropriately, sometimes inappropriately. But again, there wasn't, too much of an option as far as where these folks were going to be receiving care. If you look between 2007 and 2014, there was a broadcast that was highlighted in NPR about the geriatric ED that was developed in Silver Springs, Maryland. I believe it was at Holy Cross Hospital. Certainly when I heard this report, I took a keen interest in it because of my background as a paramedic. But what was interesting is that, they came to the conclusion that good care of older people teaches us how to take care, or good care of everybody. And that was actually a quote by Bill Thomas, who was a geriatrician that helped design that ED. That's where we first got interested in learning more about geriatric ED. And as a mid-sized foundation, our annual grant making is in healthy aging is about anywhere between $3 and $5 million a year, depending on how the economy is going. It's in our best interest to collaborate with philanthropies such as the John A. Hartford Foundation, who have the means to develop models, or the West Health Institute, who has the means to conduct the research in order to inform some of our work. We have dabbled a little bit in emergency medicine as far as geriatric EDs are concerned. Some were very successful. One project in particular wasn't exceptionally successful. And that really tied into the buy-in that is necessary from the institutions who are looking to implement these programs. And I can get into a little bit about that a little bit more as we go through our separate parts of the presentation. Next slide, please. So what we decided to do today is to really look at the geriatrics emergency department and geriatric emergency medicine in general from three very different perspectives. First, Kelly is going to talk about the research that has been conducted, what research is available, and also what research still needs to be done. The next component of this webinar will be about education and training by Marcus, and he's going to be talking about the work of the John A. Hartford Foundation in helping to educate, to train people up in appropriately providing emergency care in an emergency department. And then lastly, I'll present, for lack of a better term, a case study of one of our successful projects that helped in an organization once they identified that this was a challenge, how to kind of get around that challenge and ultimately to create a win-win both for the foundation as well as the institution as a whole. Kelly?
Next slide. Next slide, Lucy.
Slide, please.
Thank you. So thank you, Julio and Marcus. And so I'll share with the group at a high level some of the research that's happening in the GED space today. A lot of this builds upon some of the earlier points that were mentioned. And I do want to stress to the group that a lot of the research, the education, and the capacity building, these are all intertwined together. So I think you're going to hear a lot of common themes. Next slide, please. So what we know about GEDs today, I think we can really capture into three broad categories. What do we know from a research perspective from prior studies, what's already kind of been published, if you will? A lot of this work is from the CMS Innovation Grants and other independent studies. Also from the vantage point of what's happening today. So there are some large funding initiatives and some large grants that are in flight right now that's going to help expand the evidence base of geriatric EDs. And then I'll finally shed some light on some of where the research is going based on some new initiatives that are recently launched that will open up a lot of new doors in terms of understanding what's working when it comes to geriatric emergency departments. Next slide, please. So what do we know today? You know, as I mentioned earlier, I think there are probably three key areas which have helped anchor our knowledge on GED research to date. And first, I want to start with the Geriatric Emergency Department Guidelines. Now, this was a document that was produced in 2014, as I mentioned earlier on the timeline. And I should point out this is also publicly available. Now, this was a document that was put together from an interdisciplinary group of geriatric and emergency medicine societies. And really the goal here in 2014 was to identify key domains in which geriatric ED should focus. Now, this includes sections such as how should GEDs be staffed, from physicians, nurses, social workers, etc. How should they handle transitions of care for the ED? And what are the different kinds of policies and protocols should be in place in each geriatric ED? And what this has to do from a research perspective is that really helps target the areas where we should be studying based upon the specific needs of seniors within an ED environment. And so for researchers, what this really did was help us identify where should we focus our research based on the guidance of some of the leading geriatric and emergency department society groups. So really this served as a guiding document and remains so today. The second area that I want to touch upon with you in terms of what we know about geriatric ED is actually on something that we know we don't know. And that is just how many GEDs are there really? Now, from the timeline slide, the number of GEDs, that's largely an estimate based on self-report, internet searches, self-identified GEDs. So really, there wasn't any kind of formal mechanism by which geriatric EDs were recognized and accountable for. In fact, the only published study on this topic was a survey study back in 2014, and according to that survey, which was based on self-reported geriatric EDs, they counted just over 30. So there's a wide variability in terms of how many GEDs are there really out there. And part of what makes this challenging is that to date, they're self-designated with the exception of an accreditation program, which has helped shore that up, which I'll share with you here shortly. Now, of course, without any kind of formal mechanism by counting GEDs or standardizing them, there are challenges in understanding the quality of care being delivered. And so from a research perspective, one of the challenges that we have is we really don't know how many of them that there really are. So finally, I do want to touch a little bit on the CMS Innovation Award. So we've drawn a tremendous amount of insight from this early work that was initiated in 2014 and continues to this day. And I'll focus on two key findings from that grant. First is the impact of a specialized nurse in a geriatric emergency department. So one of the challenges with a geriatric ED is that it requires an interdisciplinary team. And what this grant set out to do was identify what was the impact of a specially trained nurse within the geriatric ED who can identify, detect, and provide the right referrals for seniors from an ED setting. And indeed, what they found was having a specially trained nurse within a geriatric ED was indeed associated with reduced hospital admissions from the emergency department. Now, keep in mind, one of the challenges with EDs and the challenges that they've had in years past is a high admission rate for seniors. And that was often because ED providers were either not specifically trained or didn't have the resources to help address some of the senior-specific needs. And that's exactly what this particular nurse intervention set out to do and demonstrated. We also have early results from the impact of having a social worker embedded within the ED. While we also know a social worker may be an upfront investment for any emergency department, some of the early work here that was presented last year at an emergency medicine conference showed that it actually was associated with reduced 30 and 60-day total Medicare expenditures. So recall, one of the key components of a geriatric ED is to address the medical as well as the social circumstances of the senior. And these findings suggest that having a social worker within the emergency department was able to do just that, and in this case, demonstrate cost savings. Next slide, please. So what's happening today? That was a little bit about some of the published research that is helping inform the decision-making today. Now, in terms of what's happening right now, there are a couple of key areas that I want to share with this group. First is the Geriatric ED Collaborative. So this was formalized back in 2014 and is focused on 3 key aims. The first 2, I'll let my colleagues, Marcus from the GIA Hartford Foundation, speak to, as they're more focused on the education and training component. But the third aim, relevant for our discussion right now, is really on evaluating the impact of GED. So this is really specifically focused on expanding the evidence base of what works when it comes to geriatric emergency departments. And one way we're trying to do that within the collaborative is to continue studying data from some of these early GEDs through the CMS Innovation Award, but also establishing an infrastructure and the ability to capture data to further investigate the impact of GEDs, not just for these early adopters, but to open that up to other GEDs around the country to help understand what's working and across multiple different kinds of organizations. The second piece I want to share with the group in terms of what's happening today is a recent grant that was federally funded from the National Institute of Health. So if the collaborative was developed to help build an infrastructure that continues studying the impact of GEDs, the research network, which was funded through the National Institute of Health, is designed to support research, leverage the data infrastructure, and ask the questions around what is working. And some of the goals of the research network is to understand what are the priority topic areas, and then also how do we support junior researchers in this space. As Marcus had alluded to, we're in the business here of developing emerging leaders and helping cultivate the next wave of academicians and researchers to be able to understand how GEDs are having an impact. Next slide, please. So where are we going? Can you click it again, please? There are 3 different levels of geriatric ED accreditation. Can you click it twice more, please, so we can see the other accreditation levels? Thank you. So right now, at a high level, there are exciting opportunities happening in geriatric ED research. Much of this is stemming from the National Accreditation Program, which is helping shed light on just how many GEDs are out there and what are some of the things that they're doing. At a very, very high level, the accreditation program is designed to provide a quality check or a standard, if you will, around geriatric EDs and the kind of care that they're delivering. Right now, these are largely self-designated, so there's not a lot of accountability in terms of the different geriatric EDs. Now, as part of this accreditation program, there are 3 levels of accreditation. The 2 highest levels, level 2 and level 1, have initiatives around quality improvement and outcomes data, both of which are critically important to help move forward our knowledge in terms of what's happening in the GED space and what's working. So from a research perspective, by having a national accreditation program, we're going to get additional exposure to understand what's working and the different type of impact that different models of GEDs are having across the country. And so naturally, what that'll allow us to do, we'll be able to share and learn from one another in terms of what kind of model might fit our different communities. Next slide, please. And finally, I'll close on the research section here, really focusing on these 4 different areas in terms of what do we need to learn more, both from past research, ongoing initiatives, and future studies. So one of the first things that we need to understand is really what kind of model or what model of GED is most effective. We know that there are many different flavors out there. There is no one-size-fits-all approach, from a staffing, clinical protocol, even in some instances physical enhancement. We need to know what kind of GED model is most appropriate and what kind of impact are they having across different communities within this country. The second thing that we want to be able to learn about here is what resources are most important for the ED. Right now, we use a lot of modified tools from the hospital setting. And oftentimes, many of the same resources used in the hospital setting, while in theory makes sense for the ED, practically don't necessarily work, because in an ED environment, time is of the essence. So an assessment tool that might take 10 minutes needs to be cut down dramatically to 2 or 3 minutes for applicability within an ED environment. So we need to figure out what's appropriate. Finally, we also need to figure out what's effective. So while we certainly need to understand how to modify tools, there's also a lot of different tools and resources to choose from. Again, as we draw from a lot of the hospital setting in terms of the things that we should be doing, one of the things that we need to understand more clearly is what are the things that are most effective. So which of the menu of different options for screening, for instance, should we choose that's most appropriate for the ED? And then finally, one of the key areas that we need to do as an all strong research initiative is to learn from each other. And to do that work, part of what the collaborative is doing is building a data infrastructure to be able to benchmark and to do research across multiple sites. That'll be critically important. Right now, a lot of what we know about EDs is based on a handful of early adopters, and we know that there's a lot of good work taking place throughout the country. So with that, I'll turn it over to Marcus, who will share with the group a bit more on some of the education and training initiatives happening through the John A. Hartford Foundation.
Work that's going on in research to improve ED care of older adults. I think it provides a nice overview of some opportunities that if there are funders on the call can think about investments in research to answer some of those questions that you just raised. But great, so now I will go into the second component of our overview here and talk about interprofessional education and training as a way to improve ED care of older adults. And I'll refer to a couple of the same programs that Kelly mentioned, the Geriatric ED Collaborative and the Geriatric ED Accreditation Program, and talk a little bit about how they drive education and training. And then I will also link it to a big initiative of the John A. Hartford Foundation called Age-Friendly Health Systems. Next slide, please. So as Kelly indicated, for the Geriatric ED Collaborative, there are 3 main aims, and Kelly talked about evaluating the impact and the research component. I'll talk about the first 2 aims, and I will just say it's been such a tremendous pleasure working with West Health in very deep collaboration on setting up this Geriatric ED Collaborative, as well as supporting the accreditation program. And together, we've really worked closely to think about our initiatives and how they fit together and lead to bigger outcomes for all of us. So I am putting, again, a box around these first 2 aims, transform care and catalyze action, because at their core, they both are about education and training. And as we've discussed, and I just want to have you keep in your head that all of this is very closely linked to the accreditation program that Kelly mentioned. These 2 initiatives work side by side and provide nice synergy between them. Let's go to the next slide, and you might be wondering, okay, you talk about a collaborative. Well, what does that mean? Who's involved? In addition to West Health and the John A. Hartford Foundation as partners in funding and being very engaged in the actual development of the initiative, I'll talk a little bit later about 4 national organizations that are involved to help spur this. But really critically at the heart of this are actual health systems and EDs around the country who have committed to improving their care for their older ED patients. And you'll see here we have 9 sites, really 9 systems that are part of this, what is a learning collaborative. They have both stepped up to the plate to say, hey, we will commit to making improvements in care for older adults in our EDs. We will learn from each other. We will participate in some of that research and evaluation that Kelly was mentioning. And they're going to help share what they're learning with the rest of the country and EDs around the nation. You'll note here in these 9 sites that they really do span the country and represent a range from large to small, rural to urban, academic centers to more safety net hospitals. And they're just doing really incredible work in their EDs. Next slide, please. So now back to these first 2 aims. And the first one, transforming care and how that relates to education and training. I should note that as part of our Geriatric ED Collaborative Initiative, we have a group of tremendous expert interprofessional faculty who have been conducting what are really boot camps for EDs in geriatric care. These are intensive 2-day interprofessional training sessions for an ED that might bring anywhere from 70 to 100 people together from across the ED and even from across the hospital. These boot camp training sessions begin with engaging hospital and ED leadership so that the C-suite is bought in and understands. Our expert faculty provide didactic education and are expert in delivering that kind of educational material. And again, all this is done in an interdisciplinary, interprofessional way. But the real secret here, and we call this transforming care because these
Marcus, are you still with us?
Me?
I'm sorry, you dropped for a moment.
Okay, let me know if I continue to break up.
Okay, thank you.
I will continue, and I was just saying that really the essence of the Geriatric ED Collaborative and its educational initiative is to not just provide didactic training, but also to implement that education through quality improvement programs. And that is really essential. It begins not just an educational journey, but a process of culture change in the ED. And this year, I would note that with our funding and support, we will also be offering regional ED courses as well. So these regional courses will allow teams of 3 to 4 interprofessional staff from EDs around a region to come together with other hospitals to receive similar training and guidance on implementing quality improvement programs. Our Geriatric ED Collaborative faculty then provide follow-up technical assistance and coaching. So far, the topics have included what you see here. If you're in the world of geriatrics, these will be familiar to you: transitions of care, delirium, cognitive impairment screening, falls and mobility protocols. And I will say it's been great since over the last 2 years, we've had more than 38,000 patients receiving this geriatric ED care in these 9 sites and systems. We're getting reports of positive outcomes, and we'll be working on the research side to continue to evaluate the training and quality improvement programs. So I ask that all of you in the audience stay tuned for more information coming from West Health and us later this year as we begin to promote these regional courses as an offering for you and the EDs in your community, more boot camps designed specifically for one ED or hospital, and we can definitely partner with local philanthropy on those. Next slide, please. I want to mention very quickly the second aim of this Geriatric ED Collaborative, which is about catalyzing action. And what we mean here is that we're creating educational resources and a platform so that all EDs can begin the learning process. So here, our faculty are working with the American Geriatric Society to formalize an educational curriculum with clinical tools. A website is being developed to augment existing web resources that are out there. And I included one here that's just really great from Canada and from one of our faculty members who hails from that country. And it's geriatric-ed.com. It's a great starting point, and stay tuned for even more web-based resources from this initiative. I will say the GEDC, the Geriatric ED Collaborative, is also growing and training a cadre of interprofessional faculty who can teach even more EDs through boot camps and regional courses. And finally, I mentioned them earlier, but really important to this are 4 major national organizations that have partnered with us and with our faculty to provide education to their members. And so a huge shout out to the American College of Emergency Physicians, the American Geriatric Society, the Emergency Nurses Association, and the Society for Academic Emergency Medicine. Together, through sessions at their conferences, through producing web-based resources, and other ways, these 4 organizations are committed to helping their members be better trained and prepared to care for older ED patients. Again, here, stay tuned. As we launch that curriculum and website next year, we'll ask for your help in spreading the word and promoting those resources to your local EDs. Next slide. And then I'll just wrap up with two items here. One is I do want to reference and go back to the accreditation program that Kelly noted. And he described the 3 levels of accreditation, and those offer the chance for EDs to focus and have a goal that helps them align their resources around better care for older adults, and that includes in their education and training of ED staff. So for levels 1 and 2, the top 2 levels of accreditation, one of the requirements is documentation of physician and nursing staff getting education in domains, as you'll see listed here. And again, those tie nicely to what the Geriatric ED Collaborative trains on, and these all are very nicely tied to those Geriatric ED guidelines that Kelly mentioned. So we encourage all of you to encourage all the EDs in your area to pursue accreditation. It's a way of beginning the process of improvement that can benefit older adults and their families, and we believe will also create more value for the health system as well. And just a note, we just launched this year in 2018, and we've already got 20 EDs that have been accredited at the various levels, and 55 have applications in process. And now my last slide. I want to extend this conversation and link it to another big initiative of the John A. Hartford Foundation, which is our Age-Friendly Health Systems Initiative. We work closely with the Institute for Healthcare Improvement, experts in quality improvement. They're just terrific. And we all work in partnership with the American Hospital Association and the Catholic Health Association of the United States as well. Our goal is to develop an age-friendly health systems framework and rapidly spread that to 20% of US hospitals and health systems by 2020. And this is really an opportunity with our partners to distill the best evidence that's out there, and that pointed us to 4 interlocking domains that we must address if we want to have age-friendly care. And you'll see them here. First and foremost, we must have care that focuses on what matters to the older adults, not just for end-of-life care, but with all care. We have to address medications, mentation, which gets to those common issues like dementia, delirium, and depression. And we have to focus on mobility and maintaining function. So we started with 5 pioneering health systems, helping us to build the framework and implement quality improvement programs focused on the 4 M's across all healthcare settings, and that includes the ED. We now have over 120 healthcare teams from 73 different systems participating in an age-friendly action community working on these 4 M improvements. And the wonderful thing is that these 4 M's track very nicely to the Geriatric ED guidelines and to the work of the Accreditation program and the Collaborative's training and education offerings. So again, stay tuned here for more educational curricular modules to be made available through this initiative and for other opportunities for EDs and other settings that are in your community to join into the age-friendly health systems movement. So with that, let me turn it over to Julio, a longtime partner of the John A. Hartford Foundation, and he'll take us home.
Great. Thank you, Marcus, and thanks again, everyone, for joining us this afternoon. I wanted to give you a little background on the Samuels Foundation so you kind of get an idea of our size and what the potential impact might be, and also what our strategy has been over the years. We're considered a mid-sized foundation. We're actually a performing arts foundation. But many years ago, about 20 years ago, as the endowment grew, they thought that the board thought that focusing on healthcare was another approach towards meeting the goal of the foundation, which was to improve the quality of life of New Yorkers. And over the years, that healthcare focus has been even more fine-tuned to really focus on the needs of older adults. Before myself and my partner here at the Samuels Foundation, Lauren Weisenfeld, joined the foundation, the strategy was to help to create knowledge by funding applied research. But the board had a tough time understanding how some of that work was directly helping our Aunt Tilly. And so it was decided by the board to really focus on direct services. Now, while New York City may not be the largest geographically, city in the United States, it's certainly one of the most dense. And the trick that we had to, figure out was how to improve the quality of life of the 1.8 million older adults that live in New York City. So the way that we operate, our grants tend to be in the $150,000 to $200,000 range on average for about 18 months. And we tend to use our grants as kind of startup capital to give an organization the capacity they might need in order to implement a program. Again, given my background and the work that has been done by the West Institute, as well as the Hartford Foundation, we became interested in geriatric EDs, and so have a number of the folks that we have partnered with in the past. For this particular project, geriatrics and palliative care in the ED, or the GAP ED, because it's healthcare, so it needs an acronym. We partnered with Long Island Jewish Medical Center of Northwell Health. Northwell Health is a hospital system here in the New York area that serves the New York City area, including the counties of Suffolk and Nassau County. It's the 14th largest hospital system in the United States, and it's the largest one in New York. They were, if you refer to some of the earlier slides, they were realizing the same things that many other healthcare institutions are realizing across the country, is that the number of older adults seeking care, whether it be appropriately or inappropriately, in their ED has been increasing significantly. So again, thanks to the work of the West Institute, Health Institute, and the Hartford Foundation, Long Island Jewish Medical Center came to us to seek a grant to integrate a multidisciplinary team that included geriatric and palliative care expertise in the emergency department setting. Next slide, please. They had hoped, and when we talk about an interdisciplinary geriatric team, we talk about a team that they recognized needed to include a geriatric and a palliative care physician. There has to be close collaboration and buy-in from the emergency medicine physician. They created a GAP ED navigator, which was a social worker that played a role not in just providing social work, but also as a project manager and a research associate, and also gave some support with case management. The target population, we do have a New York City focus. So the target population was Queens County residents that were age 65 and over, who were at risk for hospitalizations, readmissions, and complications because of their age and because of their chronic illness. Some of the outcomes that they were hoping to achieve was to provide comprehensive geriatric and palliative care assessment to 720 elderly patients in the ED. Next slide, please. They hope to provide or to coordinate the care for 100% of those patients who were identified appropriate for the GAP ED upon discharge from the ED, with follow-up to ensure their needs have been met. Also, education and conversations on advanced directives was one of the goals of the GAP ED program, with directives established for a minimum of 80% of patients. They were hoping to realize a reduction of at least 10% in the 30-day readmission and 30-day ED revisit rates. And I think that this is an important point that we need to think about as some of these healthcare institutions continue to roll out these geriatric EDs. One of the things that wasn't included in the timeline was really the change in the financial environment that a lot of these institutions are dealing with. With any of those changes, organizations are challenged to find approaches that might help them to, in this case, reduce those 30-day admissions and also reduce the number of ED visits. Many New York City based emergency departments are typically overprescribed on any given day, especially on the weekends. And so the ability to provide appropriate care to everyone is a real challenge when you have 110, 120% capacity on average on any of the New York City EDs. So implementing and striving for a reduction in 30-day readmission, making sure that we train up and have the appropriate staffing available at any ED to make sure that people are treated appropriately is an important part of addressing the very dynamic environment of which these organizations deal in on a regular basis. As important also was the higher levels of patient, family, caregiver, and staff satisfaction that they were hoping to achieve. They did, in fact, want quantification of cost savings as a result of the GAP ED team integration, and they wanted to make sure that they could demonstrate financial viability and sustainability of the GAP ED model for dissemination and potential replication by other institutions. One of the benefits of partnering with Northwell is that they are an institution that has 6,600 beds. They also have 22 different hospitals. They have 3 long-term care facilities and about 450 ambulatory and physician practices. So for a foundation of our size to be able to pilot a program with the understanding that if successful, it will be replicated across to the other institutions is certainly a challenge that we were very willing to take. Next slide, please. So outcomes. It was a very successful project. The program, as I said, has now is beginning to be rolled out to the other 22 emergency departments within that Northwell system. The GAP ED Navigator continues to connect patients with the needed resources and advocate for appropriate discharges from the ED. And again, this person, the social worker, is a key person and vital to the success of the institution's hope of reducing the use of the ED as a place for primary care, but also in avoiding some of those ED admissions and also ultimately those 30-day readmissions. The program has also now expanded to include patients who require an inpatient admission. Generally, while they're still in the ED, they're already doing discharge planning even before the folks are arriving in their inpatient room. Next slide, please. By implementing the GAP ED at Long Island Jewish Hospital, Northwell was able to avoid 100 ED admissions for this chronic illness population, and that resulted in approximately $1.1 million in cost savings. The original goal was to serve 720 patients, but they ended up serving 1,200 patients, 25 of which avoided unneeded ED admissions, which led to a $3.3 million in reduced cost of care over the past year. And of course, patients were very thankful and grateful and satisfied with the work that Northwell was providing to their elder patients, because they were directing folks to some of the resources that were necessary to address the social determinants of health, in addition to taking good care of their chronic illness and any of the acute illnesses that they may have witnessed. So with that, we'll be happy to share. I think this is the point of the presentation where we will be open to questions. So next slide, please.
All right. Thank you all very much for your great presentations. And we'll start out with a general question. I'm not sure who to ask this first to, but how do you see the wonderful work that you're doing now, which is in some ways a test of models and also researching the efficacy of those models? Do you see that moving out into the rest of the country more rapidly now? And what's missing to make that happen? And Kelly, we'll start with you on that one.
Sure. That's certainly my hope. So if you think about the work that's been done to date, as Marcus had alluded to, as well as Julio, there's been a lot of groundwork that's been laid to where we are today, both in terms of the launch of a national accreditation program, folks having federal grants that are funded to understand what's working. And I think in terms of expanding this across the country, that's certainly the goal. I think as a community, we're in a place where we're trying to scale more to be able to understand how this is operating in GEDs outside of those that are kind of the early adopters. The incentives that I think that we're all working towards is, how do we then incentivize health systems now to make this a part of their value proposition, quite frankly. So as the growing senior population emerges, we're hoping that the ED is a place where they start to look for to be able to provide value to the patients they serve, both that it's financially sound, that it's clinically effective, and quite frankly, that it's the right thing to do. So I think as we see more health systems see the value, opportunity to provide value through the ED, that will additionally scale in addition to the evidence that will hopefully continue to generate.
Either of the other of you want to answer that question?
This is Marcus. The only thing I would add in terms of, we are in the process of evaluating these models and figuring out what works best. But I think what we've all come to realize is that we can't wait for the definitive randomized control trial that tells us exactly which version of this cognitive screen works best in this setting. So what we've taken the approach of is let's try to accelerate as quickly as possible. So using a quality improvement framework, I think, is part of that mix. So that way we are on the ground working directly with EDs and systems, trying to improve the daily experience of care and what happens, and use that to evaluate outcomes and impact. Secondly, I have to say the power of accreditation, having a national organization like the American College of Emergency Physicians put out an easy to grasp framework for EDs to strive towards making improvements and to have a way, an easy to get way of approaching that process, I think is really accelerating the work. And meanwhile, again, we will continue to build the evidence about what's really making an impact.
Yeah, and this is really, I just wanted to add something that I left out is that the work of the Long Island Jewish Hospital wouldn't have been possible without Mount Sinai and St. Joseph's being part of the geriatric ED program. They were able to do site visits there. And it seems to us, based on our experience, that every time we are able to replicate a model successfully, especially when you partner with a multi-hospital healthcare system like Northwell, you get a bigger bang for for your buck, and it leads to continued replication and continued growth of the model. I hate to be that guy, but there's also a financial incentive for institutions, to replicate some of these programs. Yes, of course, they have a positive impact on the overall health and well-being of the communities that these institutions serve, but they can do it effectively because there is a financial benefit to some of these programs. The other benefit goes to the foundation as well. We're able to invest in some of these programs and continue to invest in the replication of this program in other institutions because it's a win-win for us too. We are successful and we're using our limited resources in a positive way.
So I'm going to follow up on that with a question for all of you about how can foundations and other funders be actively involved in this. I think, Julio, you've given us a great example of how a mid-sized organization, foundation, can be involved. We tend to think of these as enormous, multi-million-dollar activities, but could each of you comment briefly on what you see particularly smaller or regional foundations being able to do, and what needs to be done at the national level?
Sure. This is Kelly. I'll go ahead and just comment briefly. I think the first thing is really just awareness. I'm constantly surprised as much momentum as geriatric emergency department and geriatric emergency care is getting recently. This is still a very young field. And so even locally within your local health systems or hospitals, to one, first raise the awareness, and then two, helping provide a catalyst, whether it's through awareness, education, to be able to get them involved and engaged in taking a close look at whether or not their local EDs are serving the needs of seniors. And one very, very easy activity that I always start with a lot of EDs is just run a quick query, see how many seniors you've seen in the last year. And I think most folks will be pretty surprised as to the fact that they're already serving the needs of many seniors annually in their ED. And if we can formalize that through additional trainings, joining collaboratives, participating in some of the education opportunities, I think that'll go a long way in moving it forward.
And this is Marcus. I'll just add in addition to that, raising awareness and just connecting and making sure your health systems are thinking about the ED as a place to care for older adults. I think there's some concrete ways with our initiatives here at the national level. So you saw those 9 systems that are part of our Geriatric ED Collaborative. They are all very interested in working with their local regional philanthropies to build out what they're doing to make the quality improvement programs and accelerate even faster. The accreditation program similarly could use philanthropic support. In both instances, for our boot camps and regional ED training courses, for the accreditation program, there are some costs, there are some fees associated with that for EDs. We are building in a sustainable model here that we want to live beyond the life of our grant. And so there are some costs associated with EDs coming to a training or going through the accreditation process. There may be opportunities for local regional foundations to help catalyze some involvement and engagement through a competition or some small grants that kind of help that get going with a convening or other activity. So look for those opportunities, and I think Kelly and I and Julio are happy to talk, with anybody who's interested.
Yeah, that's for sure. We'd be happy to share any of the successes that we've had and also some of the challenges so you guys know what to look for. But we were talking throughout this this webinar about research, training, and also capacity building. And I think that there are opportunities, within all of those 3 different perspectives or disciplines. As far as training is concerned, we're never going to have enough folks trained in order to provide or enough geriatricians or advanced practice nurses that focus purely on geriatrics to meet the demand of older adults in the United States. But what we can do is we can train up existing workforce to make sure that anyone who works in any ED in any community is viewing these patients through an aging lens, so they understand what the benefits are of providing appropriate care and the benefits of becoming accredited in order to serve these folks best. We recognize, and certainly we don't have the means to be able to fund a complete renovation or creation of a new standalone or adjacent emergency department. Even if we could, most of the hospitals in New York City don't have the space to be able to do that. But if you can again change the culture and use some of the work that has already been done, there is an opportunity for small, medium, and large foundations to bring this geriatric emergency department model to their own communities.
Well, thank you so much. We have a number of questions still left, but unfortunately we've reached towards the end of our time. I want to ask each of our panelists now to give us their closing words of wisdom. And Kelly, we'll start with you.
Sure. Thank you for the opportunity to share all the wonderful work that's happening in this space. I think the first thing I would impart with our listeners out there is that there are resources and hubs of excellence, if you will, very nearby. As Marcus had alluded to earlier, the collaborative is spread out quite evenly throughout the country. And so you're not far from kind of an early adopter GED that can help provide guidance, as well as help point you in the direction of the appropriate trainings or some of these regional courses that will help different EDs get jump-started in their journey becoming geriatric ED.
Thanks, Marcus.
Sure, thank you. I guess one point I'd like to reinforce with the audience is that there really is an opportunity to accelerate improvements in care. And one way to do that is to approach this kind of work as not another project or not another initiative, but as a framework, as an approach. We've learned that with our age-friendly health systems initiative and with our geriatric ED work, that if we provide a motivation and a framework, and then let the local sites figure out the best way to implement improvements in practice based on the best evidence available, you can really see some amazing improvements in outcomes for older adults. So think of this as not necessarily another initiative or project, but as a framework to propose to your local health system.
Thanks, Marcus. Julio?
And the only thing that I would add is that, we don't need to reinvent the wheel, thanks to the investment that the Hartford Foundation and the West Health Institute has made. It gives funders like us who are locally based to take those models and to replicate them, because we don't have the means to create, to create new models. And, I think that we're a relatively small pool of funders that focus on the needs of older Americans. And because of that, I think that there's more of a familial feel, folks that are out there that are very willing to share best practices and certainly share any of the work to ultimately benefit the older adults in our country.
Thanks very much. I want to remind the audience that the slide you're currently looking at has the email addresses of all of our speakers, and they're, I know, very anxious and happy to talk with you or to answer the specific questions you may have. So I do want to thank Kelly Coe, Marcus Escobedo, and Julio Urbina today. We thank you for all you're doing to advance age-friendly healthcare in your state and throughout the country. We also want to thank West Health for their support of this webinar, and the John A. Hartford Foundation for their continuing support of our webinar series. We will be making the presentation available to anyone who wishes to view it later, including both the slides and the audio. Watch for an email to be sent to you in a few days, or you can always check our website. And we hope you'll join us for our next webinar taking place on Thursday, November the 15th. The webinar is entitled Dementia-Friendly Wisconsin, Connecting Through Memory Cafes and Libraries. This is a really fascinating set of activities of two groundbreaking memory cafe programs in Wisconsin that are redefining how to create a dementia-friendly community. Please attend this webinar to learn how they're doing it, to gain insight on how to bring these models to your own communities. And then finally, I want to thank all of you for your participation today. Have a great day.
Thank you.
Thank you.